Thanks for the invitation. It's just 30 minutes. It's covering a pretty broad topic. What I tried to give you in the slides is highlights, things that if you're interested in or if make you think, I'm not sure how well we're doing that at our service, you can go and dig more deeply into when you get back home. So that's what I tried to give you. We'll start with pre-hospital procedures, a comment about the new TBI guidelines, pre-hospital blood, a nod to the new triage criteria, and then conversation quickly at the end about RMOCs, or Regional Medical Operations Centers. We talk a lot about what we should do and what we shouldn't do in the field. And this article from GEMS highlighting minimalism, I think, is valid. There are some things that are definitely going to be beneficial for your teams to do in the field. And sometimes, as you know, and you all as medical directors, you deal with this. What are my teams getting into? What should my teams be getting into? What's worth being responsible for? Because with everything we do, there's risk. So that's what I tried to touch on in talking about some of these procedures. And this is how I started. So this is a paper written a couple of years ago, published in a big trauma journal, and it was looking at pre-hospital procedures with respect to which ones were associated with improved survival. Now, importantly, this is in a penetrating trauma population, so take that into consideration. At UK, we see thousands of trauma evaluations a year, but only 10% of them are penetrating. Our population in the blunt world is different. Rural is definitely going to be different than urban. But look at these hazard ratios or risk ratios for mortality. Intubation in the field associated with a 52-fold greater risk of mortality. Well, this would suggest that we shouldn't intubate people in the field. It can't be an absolute, right? There are going to be some people that are going to benefit from intubation in the field, but this suggests we should be certainly very careful about who we are intubating in the field. IO access, so there's another one. Well, that's not happening on the scene, that's happening en route. How could IO access en route be associated with an increase in mortality? Well, kind of like intubation. If they're requiring that, these are patients that are at high risk of dying anyway, right? So we have to consider that. C-spine immobilization. I think we'd all agree that C-spine immobilization in a penetrating trauma patient is certainly not helpful. Pleural decompression. This would suggest that it's associated with dying. Pressure dressings, not associated with dying. Seems to reduce the risk of dying. So that's encouraging. Maybe tourniquets do. But I think what this paper highlights is not everything we do in the field may be associated with an improvement in outcome. It means we should be careful about which ones we do and have really good indications. So I'll try to give you some more specifics here. Intubation, particularly in trauma patients, should give all of us pause. A lot of what we should factor into here is whether we can oxygenate and how long our transport time is. Is Paul Pepe, he's one of your peers, our peers, nationally known emergency physician, and he wrote this paper, Pre-Hospital Endotracheal Intubation, Elemental or Detrimental. It's basically an editorial on the topic, but he noted a couple of key things. Why intubation associated with harm? Selection bias. Those people are getting intubated in the field, they're sicker. Overventilation after intubation definitely has the potential to harm. That first big breath after intubation is going to increase intrathoracic pressure. Ventricular filling is going to fall, and the patient may well arrest just with the ventilation in a really hypovolemic patient, not to mention overventilation in brain trauma patients. And, intubation requires us to stop something in order to do that, particularly with a small team. So certainly it's of limited utility in many patients after injury. And those of us who've intubated people in the ER have certainly seen cases where we intubate and then they die, right? And this paper highlighted some key risk factors for dying after intubation: blood pressure less than 90, shock index greater than 1, shock index certainly greater than even maybe 0.8 might be associated with death after intubation. We should be careful about who we intubate. But, it's not about plastic in the airway, right? It's about oxygenation. So if we can oxygenate maybe we don't need to worry about intubation. Again, this would be with a relatively short transport time. Oxygenation is the goal, maybe ventilation to a lesser degree, particularly in the brain trauma patient. And, my new favorite thing in the ICU, and I think a favorite thing on the streets now is high flow oxygen. You can get through a lot of trouble by just inclining the stretcher, making sure the airway's open, and some high flow nasal cannula. End-tidal, for sure, is the way to go when you're managing an airway pre-hospital or in the ED or in the ICU. I ask for end-tidal all the time now to my team. And the monitors, they roam around the hospital and we lose them in the OR. And I say, where's the end-tidal? We should be paying more attention to end-tidal these days. How about this question? Hey, shouldn't I intubate the guy? Because, I'm going to put him in an airframe and it might be difficult to intubate him later in flight. Shouldn't I do it now before we take off? I thought this was an interesting paper. Dr. Cornhall is an emergency physician, an anesthetist, an emergency physician in Norway. And he looked at this question. He took a handful, a dozen or so emergency providers, experienced paramedics, emergency physicians in Europe, many of them anesthetists, and he asked them to intubate patients out on the flight deck, outside the aircraft, and again, inside the aircraft. Now, mind you, he's doing this study in Norway. 14 experienced technicians, numerous different scenarios, 100% first pass success. In the airframe, outside the airframe, of course, this would depend upon the airframe, but you can imagine, particularly in Norway, the flight crews said, we prefer in the cabin where it's not snowing and it's not 10 degrees or whatever. And they highlighted the quicker you get in the aircraft and get out of there, the quicker you're going to get to the trauma center. So maybe faster evacuation, certainly better conditions for intubation. So maybe not get too wrapped up about let's intubate the guy here before we go in case, if that's helpful too. This is a really common one that we think about. Should we put in chest tubes in the field or should we wait until the emergency department? The challenge here is that these are rarely done. It's a little bit of a challenge now. Experienced emergency physicians in the crowd can appreciate this. To get trainees, surgeons, and emergency physicians enough tubes that they're finishing competent. And we went through this phase where we were pretty excited about small bore tubes. You guys remember the old days, the old people in the crowd, looking at Dr. Hilty and others in the crowd who remember these chest tubes loaded on trocars. We were like, whoa, careful, the pointy object. But past few years, we got really enamored with these 14 French things loaded on an even tinier, sharper trocar. And they're fine. The problem is the proceduralist never has to put their finger in the chest. Right? And there's just something about that, like pushing through the pleura and feeling that soft jelly lung and going, I'm in. That's really valuable, and we need to continue to reinforce that for the young trainees. And I tell them, I tell my senior residents in surgery, I know it's easy for you to knock that chest tube out, but don't. It's the wrong thing to do. You take that PGY2 emergency medicine resident and you make sure they know how to do it, because they're going to save a life someday. Out at St. Elsewhere, they need to finish knowing how to do this. That's in the ER. That's in the ICU. How about in the field? It's a relatively rare procedure, right? 0.2% of cases, trauma cases, are going to need a chest tube. So it's relatively rare. Anything that we don't do very often, we have trouble maintaining competence. Access to the chest has been reported as rarely as 1 in 20, depending upon the study. Maybe 100% of the time, but, right? I was making rounds this morning. My resident said, it's one of the EM residents rotating on our server. He goes, hey, I put a chest tube in this guy. And I said, is it in the pleural space? And he said, yes, sir. And the chief resident said, I was there. I said, okay, look, I'm just asking, because I've certainly seen it. And you all have seen this in your career. Chest tube, not totally in the pleural space. So we can't criticize the medics because we do it too sometimes, not get all the way in. The needle size probably needs to be close to 3 inches to really get all the way in, particularly in bigger patients. Iatrogenic injury, maybe 1 in 8. We've all seen it. Diaphragm, lung, subclavian, intercostal vessel. That's the most common one because we end up under the rib rather than over. Cardiotomy, we've seen that. Not we've seen that, but it's been reported. And how often does that improve the patient? Maybe as little as 5% of the time, maybe 50-50. I think the most important thing for you to be teaching your medics and reinforcing with your medics is that they're needling not here like we used to in the second interspace, midclavicular line, but here where we would put in a chest tube. And I teach them nipple line or above in this sort of anterior axillary line. This is the thinnest place in the chest wall. And Kenji Inaba's picture's up here. He's in Los Angeles because they've done a series of studies looking at cadavers and looking at CAT scans, and that is truly the thinnest part of the abdominal wall. That's where they're most likely to get in, chest wall. So fifth intercostal space, anterior axillary line. More accurate, easier to get in. It's just as fast. Use that. But does it really work? I was encouraged to see this paper published from the Pennsylvania Trauma System, massive trauma system, huge database. This is 1,400 patients who got pre-hospital needle decompression compared to 7 patients who got thoracostomy right after arriving in the ED. So arguably could have been needled in the field. And how do those two groups compare? So needled in the field just sometime before arrival, or chest tube right on arrival. Arguably could have been needled sooner. And look at the results here. In the primary analysis, risk of mortality goes down with needle in the field. In the propensity match cohort based upon injury severity, mortality goes down. If you look at it within certain EMS agencies, maybe it's a training issue. One service is better than another. Still, if you look at it by EMS agency, mortality goes down if you needle in the field. Patients who survive the ED stay, even the brain trauma patients, any way you analyze it, ground versus air, this study would suggest that yes, it's beneficial. So we need to continue to teach it, and we need to continue to do it in the right patient. I think this is helpful. I kind of like to look at what TCCC says, because if it's something that somebody should be doing in a firefight, then it's reasonable to think that it's something we should do in the civilian EMS setting. And this is what TCCC says. Have an aggressive approach to patients who might have tension. So we teach our teams, this is what tension looks like. If you see that, you needle. Cardiac arrest, make it double. 10 gauge, 3-inch needle, 7 centimeters, some big long thing. This site, TCCC, maybe midclavicular lines still, but this is the site we need to teach. 2 attempts and then put your finger in. And we should be training our teams how to do that. Okay, how about IV access? Nothing's changed here. IV access on the way. You wouldn't do it in the field. I like this saying, the most important fluid, pre-hospital fluid in the treatment of trauma patients is still diesel fuel. So drive fast, get your IV en route. I think this is really important, though. This is the PAMPER trial. This was pre-hospital plasma versus something else. So the something else could be reds. Something else could be crystalloid. But how about pre-hospital plasma? University of Louisville participated in this as one of the sites. This was published a couple of years ago. So, we think bleeding patients, red stuff is running out. And, the real experienced folks in the room, Dr. Bentley and others, remember the history here, right? The history was guys bleeding. And this is back when we grew up in the 80s and 90s. Guys bleeding. So we'd say, well, we better stop some bleeding. Let's go. So we set off about stopping bleeding. And somebody would say, better get some blood. And they'd go, yeah, we need blood. And they'd go to the blood bank and they'd say, we need blood. And the blood bank would say, here's your blood. And it would be blood, sort of. Like it would be red things, packed red blood cells. So we would set off about controlling bleeding, and we would start giving the red things. And then sometime after that, somebody would go, hey, we should check some coags. We'd go, yes, we should check some coags. Let's check some coags. And, 20, 30 minutes later, the INR would come back and it'd be 2.3. And we'd go, holy cow, we better get some plasma. So we call the blood bank, and we'd say, blood bank, we need plasma. They'd say, no problem. We'll get thawing. We'll be ready in about 40 minutes. You remember this, Dr. Billy. This was our history. Now, it wasn't the killing fields. We saved most people, but, right, there's a problem with that. It was a very very reactionary approach to correcting clotting problems. And this PAMPER trial is addressing that clinical question. And of course, this has stemmed out of massive transfusion protocols that were born out of Operation Iraqi Freedom and Enduring Freedom, where we realized, they're just coming off of a Black Hawk. They were wounded 30 minutes ago. They've had no fluid, and their INR is still 1.8. What's going on? It's the first time we really had good point-of-care testing, and we were finding coagulopathic injured soldiers very early after wounding, and we started thinking we better give some plasma early. This is a civilian test of pre-hospital plasma versus something else, something not plasma. And you can see the survival curve here. The plasma group had much better survival than other stuff. So this supports, okay, yeah, maybe we wouldn't wait at the scene to get it in IV, but if we're going to give something, let's give something in the field that clots blood, like plasma. How about tourniquets? I'm just showing you the data here on the tourniquets. These are put on by all kinds of people now, EMS, law enforcement, lay people putting them on. About 3/4 of them in the field, 1/4 of them en route. And what's the deal on tourniquets? Less shock in people who got tourniquets before arrival, same mortality, no limb complications, probably safe. I do think we're probably not teaching our teams enough, just good old-fashioned, really firm direct pressure. And if you can get it like that, you don't need a tourniquet, even if it means enlisting some person to do that, and you stay right there and squeeze that really hard. But if you have to, put a tourniquet on. The American College of Surgeons is pretty clear on tourniquets. Do it if direct pressure is ineffective. Use a commercial device that's made for this purpose. Avoid narrow or elastic bands. Avoid improvising, of course, and avoid taking it down before definitive care. I think that's different. When you're in the ER, it's so easy to practice where I practice. I got all the specialties I want. I got all the radiology I want, all this stuff. When you're in Harlan with a really bad ankle fracture that's open, that's harder because you're 3 hours drive. It's probably worth taking that thing down, making an honest assessment of, do I really need this tourniquet, or could I just put a really tight ACE on there and basically have hemorrhage control? That's going to be better than leaving a tourniquet on for 3 hours. I would be careful about the long transport time. A note on stop the bleed. Anybody teaching stop the bleed? Their teams are teaching stop the bleed, yeah. So stop the bleed is going to get, it's a new version coming out next month. And it's going to be a lot fewer words and a lot more pictures on the slides. It's going to be much more adaptable to populations who don't speak English as their native language. It's really good. They had a professional artist create the diagrams and stuff. Like, instead of having a picture with blood spurting out here and a bunch of text on the slide, it's a picture with the artery and the arrows pointing like this, like this is the way the blood's going. There's the hole, put the tourniquet here, really simple. New version of Stop the Bleed coming, but they're going to hard reboot everybody's instructor status. So all your instructors will have to go in and re-up with the American College of Surgeons as part of the process. I don't have to talk to you guys about spinal motion restriction. I do worry sometimes that there's a little bit of fast and loose with respect to spinal motion restriction. I'm not a guy that fears lawyers. Been sued. Most of us in the room been sued. I don't practice according to lawyers. But man, in the middle of an intersection, cars all busted up, cars whizzing around, tons of adrenaline in everybody, the patient and the EMS professionals. Is that the time to clear a guy's spine? Oof. I personally feel like it's not very much worth the risk, because shoot, I debate with my partner, should we image this guy's spine, or with the ER team, ER goes, look, I cleared him, I think he's fine. And I go, I know, but you should probably do it. It's usually not me, it's usually some of my younger partners like, oh, we got to image everything. Anyway, we disagree. 72 degrees, plenty of light, we disagree. Should our EMS professionals be clearing edgy ones in the field? I don't know. I thought this was interesting. Reboa was hot, and Reboa sort of backed off, and Reboa's been put in the field and all kinds of wild stuff. I included this in here just because I thought it was interesting. This is the UK Reboa study that came out from Europe. Standard of care here. This is survival. Standard of care here. Reboa and standard of care here suggest that it doesn't help you. Reboa is now out, is sort of backed out. The people that make Reboa, the Priton people, and they're retooling the balloon. It's going to be a partial occlusion balloon. Anyway, this is the least of my worries. When I have young, excited partners come and say, Reboa, we should do Reboa. I go, that'd be great. Why don't you look into that? I say, figure out how to consistently get arterial access in the groin without hurting anything quickly. And once you can do that, get an A-line in the groin quickly, no harm, then we can talk about sticking a balloon up the patient's aorta. Police transport, definitely worthwhile. Not super relevant in much part of Kentucky, but looks like it's safe. Short transport time, throw the guy in the car and race, and it's probably okay. Thought that was interesting. No difference in outcome, police transport versus EMS transport. This is urban by and large, penetrating trauma. Okay, so in summary, airway, probably not unless it's a long transport. Needle, for sure, if there's shock or tension. Crike, sure, cannot ventilate, cannot oxygenate. I didn't show a slide on that. IVs en route. Fluids, absent radial pulse. Fluids are reasonable. TBI, totally different population than somebody with penetrating trauma. We've got to maintain perfusion pressure to the brain. Tourniquets, if pressure is unsuccessful, direct pressure. Spinal motion restriction if they have symptoms or if they have no exam or an unreliable exam. I think there's a lot of people like this who are getting cleared in the field, but Reboa probably not. Police transport, yeah. Okay, just a few more things to mention here, and we can have Q&A as much as you want. I've not fully digested these guidelines, but these are out, they're fresh, they're very detailed. It's a 32-page article on the topic. These are the areas discussed: oxygen, blood pressure, temperature, Glasgow Coma Scale score, measurement, monitoring, pupillary exam, airway ventilation, oxygenation, fluid therapy, and then all these things specifically: hyperventilation, hyperosmolar therapy, and decision-making around dispatch, on-scene therapy, and transport. If you haven't fully digested this, I suggest your training officer or somebody from your service get this document, disassemble it, and see how much these recommendations align with what your service is currently doing now. Pre-hospital blood. Pre-hospital blood's talked about a lot. Apparently there are 180-ish municipalities in the nation now that have deployed whole blood, or components at least, into the field. And it's hot. This is a paper published a few years ago, and it suggests that pre-hospital blood, whole blood, in this case, reduced death in the ED. So you can see the numbers here. 7% death in the ED versus 0 in the pre-hospital transfusion group. So does pre-hospital transfusion bring us a more viable patient? That'd be the argument. If a guy came in the ED, injured, with evidence of hemorrhagic shock, we would say, get me some blood. And if the person asked us, they wouldn't. If they said, how soon do you want that, doc? Where do you want that to be on my priority list? You would say, right away. Okay, so how do we translate that into the field? That's the idea here. So there's a lot of conversation about it. And we're making a little bit of progress. In Lexington, we got a group together recently. Dr. Hilty was there. We got 4 services in and around Lexington who are interested in giving whole blood in the field. We're going to model it after the Southwest Texas regional, I forget what they call it, whatever, RAC, the STRAC. Yeah, we're just going to use their protocol. And Kentucky Blood Center is into it, and they're going to make some blood product available, and we're really excited, and we'll see how it goes. Field triage, the triage guidelines got revised a couple of years ago. You should know about that. And if your team hasn't digested these and implemented these, then it's something you should give priority in your service. And lastly, let me just finish with a comment on RMOX, because this is super relevant right now. this week with the flooding in Kentucky. Let me frame out the RMOCs like this. I was struggling to get my head around medical operations centers. The idea is you've got a central kind of dispatch in a region, maybe a multi-county region, and that MOC, that medical operations center, is helping coordinate care. That makes sense to me. I was a helicopter dispatcher at UK. I did flight following. I took a lot of phone calls and did all that stuff and made ambulance runs for a while. So I get the whole dispatch thing. But I was sort of struggling to get my head around the scope of this. And then somebody explained to me a few weeks ago, he said, here's how I think about it. And this is somebody who's at STRAC in San Antonio. He said, here's how I think about it. There's a building collapse. Say there's a bomb. Bomb goes off. And you activate the EOC. That's what we do. So we've activated the EOC. And there's pretty standard work for the key players at the EOC, right? The police chief would say, send 20 squad cars or whatever, 20 officers. The fire chief would say, send 5 engines, 2 ladders, 1 squirt, whatever it is. The EMS director or chief would say, send 10 ambulances, right? They've all got a routine for how they do this. And those units would be dispatched to respond, and they would have a standard way of responding. What do we do about the hospital beds? Because we don't really have a great way of doing that now, if you think about it. So a medical operations center is sort of like the EOC if the hospitals were represented and got together and worked together. Make sense? So now you have the major hospital systems. So like in Kentucky, it would be Catholic Health and Baptist and UK and Norton's. Those would be some of the big ones. And they would be in the MOC when something was happening. And the call would come in, we need 5 beds, ICU beds. And one of the individuals, they're all sitting there looking at each other, and there's a big bed board with all the beds. And then one of the healthcare systems goes, I don't have any beds. And then his or her peer looking across from them, looking them right in the eye and looking at the bed board goes, are you sure? Because I think you've got some beds. Well, that one's held for, whatever, cardiac, this and that, Dr. So-and-so, right? And this is now when we come together at the Emergency Operations Center as peers who have beds, and we work together just like EMS and fire and police does. That's basically a medical operations center. We could have used that early in the week when stuff was happening with respect to the flooding, right? So this is how this might work as a nation. You might have these big federal level controlling agencies, these regional MOCs, and then these sub-regional MOCs that would be within states. And this is how it might look. There's your MOC in the middle. We would do some injury prevention, some education and training. When the crisis came, the EMS response is there, and some patients would go here. Some patients would go to the level 1 or 2. That would be dictated by the MOC with load leveling, not everything going to the level 1 or 2. And then, of course, we would shepherd the people all the way out into rehab. Research would be part of this. We would identify vulnerabilities in the system. That's the idea. Why is this such a hot conversation right now? I think the flooding early in the week, this is just an email I got from Dick Bartlett saying, hospital's flooded, we're going to need to reallocate patients, be aware. The MOC would step in this case and help with this patient reallocation. But this is the really hot one. This is a seminar coming up at our national meeting in a couple of weeks around, as you can see from bullet number 1, military preparedness. As the military anticipates large-scale combat operations. This has become a routine conversation at our big trauma meetings, is that we should be prepared to enter into military conflict, and we should be prepared to repatriate large numbers of injured soldiers back into the U.S., like maybe to the tune of 1,000 to 2,000 injured soldiers a day for the first 1 to 2 months. Well, where are we going to put 90,000 injured soldiers suddenly repatriating to the U.S.? Or repatriating to the U.S. 1,000 to 2,000 a day? Where do they go? An organized medical operations system on a state or multi-state regional level or national level would allow us to allocate those patients out into the civilian trauma system. That's everything I have. Walt, I hope that met your expectations. I'm happy to take questions. That's not everything about trauma. Those were the big ones that I came up with. Happy to talk about whatever you all want to talk about. Hollis? Blood and plasma. Yeah. Yep. Yeah. The EMS deployment of plasma, we weren't involved in Pamper, so I don't know how exactly they did it. I suspect they did it with liquid plasma, never thawed. It was about 21 days-ish. KBC, Kentucky Blood Center, doesn't produce it now. First step would be to get access to it. And then there would be, appropriate storage. And then a protocol. And it could be the same protocol used for whole blood. Within whole blood, if I had to pick one thing in there that I think is the highest value, it would be the plasma. Next would be the platelets. Third would probably be the red cells, because the patient will tolerate the anemia. They just won't tolerate the coagulopathy. I think there is definitely opportunity, although the EMS application of plasma would be challenging. First, you got to get it, and then you got to store it. Same way with the whole blood thing. And there would be some risk of expiration. It's a cheaper product. People go just sort of donate plasma for other reasons. You don't feel as bad when it wastes, but still wastage would loom large in that sort of model. I do think frozen plasma in smaller hospitals could be deployed more. If you're going to be in that ED for 30 minutes waiting for a helicopter and it's a patient who is bleeding, one of those people that we've decided we're going to give whole blood in Lexington or Jessamine County or Madison or Scott, you could have a protocol, tell the blood bank, thaw really fast. And you get whatever new technology is available to thaw as quickly as you can. You can't microwave it, but you got to thaw really fast in a water bath. And then you give it to the helicopter as they go, or give it to the ground unit as they take off. And you're getting early plasma in. Maybe not in the field, but the ED, we could apply it a lot more than we are. I think without a lot of wastage. Eric? Sir? For thaw time, you mean? So tell me again. 20 minutes, thaw time. Okay. Got it. Got it. Every other bag. That's good. I may quote you on that. Oh, another one. Yeah. Thanks, you all. Appreciate the work you're doing out there. Walt, thanks for the invitation. Yes, sir. TXA? Oh, my gosh. Eric, do you want to take that one first? This is what I say. I say the same thing. I say the same thing. Definitely. It's low risk. There are some TXA haters out there, and I don't think it should be their number one priority, but it might help. It might help. Shoot. Not a lot of other alternatives. We had somebody come and speak we got a little pre-hospital conference we do every other month. I had somebody come speak from the United Kingdom. They've done a bunch of work in this, not just in does it work, but how to deploy it across a national EMS system. And the evidence is decent that it might help. There's very little evidence that it would hurt. And I would say tell your folks to give it as 2 grams. Walt will comment. 2 grams, just give it. I think Walt may be like a little bit of a TXA hater. So we could probably, you probably give it. No, sorry. Hey, I will say, Walt, when we were in San Antonio a few weeks ago and they were talking about whole blood, It's a big room. There are probably 75 people all over the country, blood bankers, EMS people, emergency physicians, EMS directors all over the country. The guy that was moderating the meeting, Eric Epley from STRAC, he said, hey, those EMS protocols in Kentucky, he said, those are the best I've ever seen for giving blood. You've got to have, I said, I think I know the guy who helped write that. So props to you coming from Southwest Texas. Yeah. Yes, for sure, right? Because, as Eric knows, the thing that most predicts open fracture infection is not how quickly the fracture gets washed out. Remember, orthopedists in the old days used to be up in the middle of the night washing out open fractures all night. They don't do that anymore. Why? Because that matters a tiny bit. What matters a lot is timely administration of antibiotics for open fractures. So if you get the antibiotics in, your orthopedist can not rush in the middle of the night, just do them first thing in the morning. I love that idea. I think it's really impactful. We should study it. Thanks, you all. Sir.